Dr. Kulji.
Good evening, sir.
Good evening, sir.
Good evening, ji. Good evening.
Good evening, Japesh.
Good evening, sir. I think, sir, Dr. Deepak is just joining, sir. So just wait for a couple of minutes. Good evening, sir.
Good evening, ji.
Good evening, sir. Thank you very much, sir. I think your schedule is very busy was today, sir, Dr. Kuljit, sir. But thanks for giving us this precious time, sir.
Thank you. Thank you. Welcome, brother. देखो करी मेरा आवाज करी नहीं आवाज कर आवाज साले मैं करके ले आया नहीं कोई वो सही है कि करिए सारे बंदे ने ताई तो पंगा एक और दवाई आती है तेरे को वो तो नहीं मिली शुरू की नहीं रिकवर तो नहीं मिली अभी रोक रखी है आनी है तो रखूंगी तब
Very good evening, sir.
Very good evening, ji.
Yeah, I think Dr. Deepak has joined. So once again, welcome, Dr. Deepak. I am audible, Manju?
Yeah, you are audible now, yes.
Yeah, good evening, sir.
Good evening, good evening.
Good evening, sir. So, and I think, sir, all the delegate has joined. I just check it out, sir. Dr. Ashish Garg has joined. Dr. Jori Gupta has joined, sir. Dr.
Hello,
Ashish Garg also joined, and Dr. Prashant. Dr. Sigla, I think I have seen, sir. He has joined. Yeah, he has also joined, sir. He has also joined. So, shall we start, sir? If you allow me, so.
Yes, definitely.
Yes, sir. Welcome this expert forum meeting, sir. So, on the behalf of Cipla, sir, I am Arvind, Regional Sales Manager at Ludhiana, sir, and I personally welcome to all, and firstly welcome to Dr. Deepak Katyal for and giving this such a beautiful program permission to us. So, welcome, Dr. Deepak. And also, I welcome to personally Dr. Johnny Gupta, sir, MD physician, sir, and Dr. Prashant Mittal, sir, from Mittal Hospital, and Dr. Sanjay Singla, sir, MD physician and cardio practice at Omni Hospital, Patiala. Also, Dr. Ashish Garg, sir, from Neelam Hospital, Rajpura, and Dr. Kuljit Singh, MD physician, Govind Hospital, Patiala, sir. So, welcome all to you, sir, in this expert forum, sir. And you know, sir, we are organizing this program, sir. So, what is the role of MRA in a daily in heart failure role, sir? So today this is the purpose to beat, sir, and one-to-one question answer session, sir, which we are organizing, sir. And Deepak, Dr. Deepak Katyal is a DM cardiologist, just will host this program, sir. So once again, all the delegates and over to Deepak, sir.
Yeah, we're good to start.
Definitely, sir. Definitely, we'll start.
Is it visible?
Yes, sir.
Yes, sir. Slides are visible.
It is visible,
Okay.
sir.
The topic for today is glucocorticoid receptor antagonist in heart failure, and this is a very pertinent topic. A very pertinent topic because heart failure, as we all know, it is a big morbidity to the mankind. Heart failure affects almost 1 to 1.5 lakh individuals per year in the form of mortality itself. We are talking about 1.5 lakh deaths per year in India. If we talk about the world scenario, the prevalence of heart failure is 26% worldwide. Almost 1% of the adult population they develop heart failure, and prevalence increases with age, rising to almost 10% among people of more than 70 years. But the Indian data is that every year we lose almost 1.5 lakh patients to heart failure itself. So, if you look at the class 1 therapy indications for patients with heart failure of infection, we can clearly see that all the guidelines they include MRAs as the class 1 indication drugs. Obviously, other drugs are ACE inhibitors, ARNIs, ARBs, beta blockers, and DAPA and come into the loop. Diuretics, they form a class 1. So MRAs, mineralocorticoid receptor antagonists, they are a class 1 certified drugs for heart failure patients. MRAs have been shown to provide morbidity and mortality benefits across the spectrum of HFrEF patients. And the basic conceptual framework behind using MRAs is that combining an ACE inhibitor and sulfonylurea or eplerenone, for that matter, achieves a more complete inhibition of the RAS, and it produces more benefits compared to ACE or ARBs alone. So why do we need this additional for a complete inhibition of RAS system? Basically, aldosterone, which is produced by the RAS, it stimulates cardiac fibrosis. MRAs block this aldosterone-mediated increase in the collagen synthesis. Thereby, they reduce the erythrogenesis also, because we know that fibrosis exposes to erythrogenesis. Thus, they reduce the incidence of. Firstly, they are reducing remodeling, and then they are reducing erythrogenesis. Thus, they reduce the risk of sudden cardiac death and atrial fibrillation, which are the main arrhythmic disturbances or the terminal events, we can say, in heart failure patients with reduced ejection fraction. So, importance of the timing of initiation was long recognized, and following, we have to understand a concept called aldosterone escape. Why we need to combine a MRA with a ACE inhibitor or a ARB. The point is that when we initiate a patient on ACE inhibitor or ARB, the aldosterone levels, they have a fall, initial fall, but then again in almost all the patients, the level of aldosterone they rise again, and indeed they return to baseline. This phenomenon is called aldosterone escape. So once the aldosterone levels are back to normal, the aldosterone can continue doing its remodeling, promotion, and fibrosis, which predisposes the patients to all the comorbidities. So, aldosterone promotes the release of angiotensin 2 via the positive feedback loop. Progressive escape is thought to contribute to ACE inhibitor resistance, whereby the effect of the ACE inhibitor becomes blunted, and the beneficial effects on mortality decreases over time in a patient of HFrEF. MRAs are able to antagonize the deleterious effects of aldosterone, thus causing the mortality benefits that we see. So the MRAs should be used as early as possible along with the ACE inhibitor or ARB along with the beta blocker, preferably at discharge after an episode of decompensated heart failure. So this aldosterone escape is the main thing which mandates the use of MRAs. So the RAILS trial was the first trial which showed definite mortality benefit with the initiation of spironolactone compared to placebo in patients with reduced ejection fraction. All the patients included in the study had an ejection fraction of less than 35%. Further, EPHESIS trial, in this recognition of aldosterone as a mediator of ventricular remodeling fibrosis led to its investigation in patients with LV dysfunction. EPHESIS trial basically included patients post-MI, heart failure post-MI. They were included in the EPHESIS study. So eplerenone was seen to reduce the time to death from any cause and the composite of time to cardiovascular death or first cardiovascular hospitalization. The majority of patients, they received a concomitant ACE inhibitor or a ARB. Initially, the studies were in patients with severe reduction of ejection fraction. Most of the studies, they had patients who had less than 35% of EF. But then EMPhASIS HF trial, it tried the clinical efficacy of an MRA in patients with HFrEF, but with mild symptoms. NYHA class 2 symptoms and LVEF of less than 35%. So there was a clear benefit between placebo and eplerenone, and EMPhASIS HF clearly showed that the hospitalization for heart failure or death from all cardiovascular causes was decreased among patients with MRA use. If you look at the various guidelines, all the guidelines in chronic HF, in post-MI LV systolic dysfunction, they uniformly recommend early initiation of MRAs, whether it is European Society, Heart Failure Society, ACC/AHA, or the Canadian guidelines. So they all give a class 1 indication to use of MRAs in these patients. What are the agents we have? What are the differences between them? We have been using spironolactone for a long time. We have been using eplerenone as well for a couple of years now, more than that. The main difference is that spironolactone is a non-selective MRA, in the sense that it blocks the along with the MRAs, it blocks the androgen and the progesterone receptors also. Whereas eplerenone is a selective MRA blocker. So by this virtue, spironolactone gives us all the gynecomastia kind of side effects that we see in patients. Absorption wise, spironolactone has got 100% bioavailability with food, whereas eplerenone is almost 70% bioabsorbed. Distribution is 90% protein bound for spironolactone, and for eplerenone it is 50% protein bound. The metabolism is hepatic for spironolactone, again hepatic for eplerenone as well. And the excretion is primarily renal for spironolactone, similar for eplerenone also. The interactions are an important thing because eplerenone is a CYP3A4 substrate. It is metabolized through the cytochrome P pathway, 3A4 pathway. So because of this interaction, we have to keep a check among the, the concomitant drugs that the patient is receiving. If the patient is on any drugs which also use the CYP3A4 pathway, then we have to clearly monitor the potassium levels, because these drugs can interfere with the excretion of epinephrine and can result in hyperkalemia. If concomitant administration of those drugs is required, then the epinephrine dose must be reduced, or therapy should be temporarily interrupted to reduce the risk of hyperkalemia. For dose adjustment, as long as the patient is, less than 5.5 level of potassium, we are okay with the routine doses that we use: 25 milligram OD, 25 or 50 milligram OD of spironolactone, or we can start epinephrine at 50 milligram per day and then increase to 100. But as the potassium levels, they go beyond 5.5, the dose need to be decreased. Between the levels of 5.5 to 5.9, spironolactone should be decreased to half the initial dose, at which the potassium levels have increased to more than 5.5 to 6. And if we are using epinephrine, again the same thing applies. We have to decrease the dose by half. And if the potassium still maintains beyond or close to 6, we have to interrupt the therapy and check potassium levels after a week. If the potassium is more than 6, we have to stop spironolactone and epinephrine as well. Both of them should be discontinued at any levels of potassium more than 6. So the current guidelines, they recommend that in patients of HFrEF, reduced ejection fraction, MRA is recommended to reduce the risk of heart failure and hospitalization of death. It receives a class 1 indication. In patients with preserved ejection fraction also, MRAs may be considered. They may be considered as an additional drug to reduce the risk of hospitalization. Caution should be exercised when MRAs are used in patients who have a serum potassium concentration of more than 5, and patients those who have renal impairment like GFR of less than 30, or a baseline creatinine of more than 2.5 in men and more than 2 creatinine in women. These patients, we should take real caution in starting MRAs. That's all. Thank you. Any questions? I would like to ask a couple of questions myself, just to keep the discussion interactive. Dr. Kuljeet, hello. Am I audible, sir?
Yes, sir, you are audible, sir. But I think Dr. Kuljeet mic is mute, sir.
Okay.
Please unmute, sir.
Sir, just to keep the interaction going, I just wanted to ask, what percentage of patients in your practice do you see clearly in class 3, class 4, or you see mostly patients who are like class 1, class 2, NYHA class 1, class 2 maybe? What is the routine spread of patients in your practice?
सॉरी कुलजीत सर, आपका माइक ऑफ है.
Mic, sir, mic.
Sir, you can just.
Hello.
Okay.
Yes,
sir, audible.
Are you audible, sir? Sir, are you asking how many patients in heart failure I am looking in my practice?
Sir,
in a month.
What is the distribution? What is the spectrum of those patients? Are they all like NYHA class 2, class 3, or maybe class 4 patients? Or you usually see mild HF patients, NYHA class 1, 2?
All type of class I am dealing.
Okay.
Class 2, class 3, class 4.
Mm-hmm.
I am handling.
What is the most frequent?
Most
frequent kind of spectrum?
Sir, more frequent 1 and 2 patients in a day.
Okay. NYHA class 1 and class 2.
In class 4.
Mm-hmm. Acha, they are all.
2, 3, 2.
The majority are in class 3 and class 4.
Majority of class in emergency cases, majority of class 3 and 4.
Okay. Okay. And what kind of diagnostic test do you rely on?
Normally, sir, normally class 1 and 2, 10 to 15 patients in a day.
Okay. So you have a huge number of heart failure patients coming to you. Diagnostic.
Yes, sir. Yes, sir.
diagnosis wise, sir?
Sometime overlapping with we can say any pulmonary disease, might be bronchial asthma.
Okay.
With crepitations.
Another thing I wanted to ask, sir, apart from clinical diagnosis, what else? Sir. I mean, from the lab point of view, what else do you rely on? Are you using BNP and other tests very frequently for diagnosis, for biochemical diagnosis?
Sir, BNP in my clinical practice I am using very less.
Okay, so clinical judgment and
just clinical judgment. I'm put on medicine only. Okay. Basically, in my practice, poor patients are falling.
Yeah, that's correct.
So they don't have money to spend a BNP test. Some of patients in a month 1 and 2 for BNP test.
But most
basically
of the time,
on
sir,
clinical judgment,
I totally agree with you. Because most of the times, I think 80-90% of the patients are clear cut in the history and examination wise. We can make a diagnosis that the patient is clearly of reduced ejection fraction heart failure patient. It is not very frequent that we are really confused between a pulmonary etiology and a cardiac etiology.
Yeah.
So clinically, I think we are safe.
Yes, sir.
Most of the times.
So basically, after settle the patient, sent for echocardiography. It shows the ejection fraction of the patient and any ischemic. They have ischemic heart disease or like that. Sometimes patient with MI with the heart failure.
Correct.
They are also handled. After that, after settle the patients, then I have sent to echocardiography. So it shows patients had post MI ejection fraction 20, 23%, 25%, 30. Then I decided it happens after the post MI heart failure.
Dr. Sanjay, good evening.
Good evening, sir. How are you?
I'm good, sir. I'm good. How are you?
All well, sir. All well.
Good evening, Dr. Sanjay.
Good evening.
Any comments you would like to make? Anything you would like to add?
Sir, in my opinion, I am using anti-proBNP in almost all the patients of heart failure.
Correct.
It gives us a very good prognostic value. And second thing is when we just show the patient that at the time of admission his anti-proBNP was 5,000, 6,000. At the time of discharge, it is just 1 or 2,000 or maybe in the hundreds only. It gives confidence to the patient and also to the clinician also that we are doing the good work, and the patient is also convinced in terms of his elevation of his symptoms, and also that his biochemical tests are improving, because it takes around 6 months to 1 year to improve the EF. At least 6 months to 1 year if there is some improvement in EF. But anti-proBNP, it improves like anything within 5-7 days if we give GDMT to the patient.
Correct. That's correct, sir.
And second thing is
basically cost wise we are sitting in that area. Basically, patient are not affording for BNP test. Then what to do?
This is the problem. Also comes that anti-proBNP report, if we send it to a lab, it comes after around 48 hours. But in my setup, I have this machine that gives anti-proBNP within 15 minutes.
Okay. The cost of the test is?
It is 2,000 rupees.
Basically, sir, cost-wise, patients are not affording.
Yes, sir. Dr. Kuljeet, that is totally correct. We do not expect the use of
most of the times we rely only clinical judgment only.
Majority of the times it is
because for echocardiography also we have to set the patient 15 kilometers away Sangrur. That is the nearest center we can send the patient.
Yeah.
If we get an echocardiography and anti-proBNP done before admission, it gives us a very good indication. It gives us a very good prognostic value also. And I have seen right now. I just examined a patient who was discharged 4 or 5 days back. At the time of admission, his anti-proBNP was 9,000, and when he was discharged, it was 1,000. Right now, today also I got it done. It is just 200. So that means the patient is also convinced that I am getting the best of treatment. and second, the patient is also getting symptomatically improved. So it gives confidence to us also and to the patient also.
Sure.
And if if we explain it well to the patient, I don't think 90% of the patients, they get convinced that this test should be done.
Yeah, that's correct.
Only thing is how we convince the patient basically.
But anti-proBNP levels, or for that matter, any biomarker, if we can, kind of plot a graph and show to the patient that, see, the patient is improving, the improvement is there very much clinically also.
That I know, sir. Clinical improvement is always there, but if we show the patient that
visible idea
improving
on biomarker level as well.
Yes.
Yeah. Sir, when do you start the MRAs usually? Like after you have started the patient on?
No, sir. As per recent guidelines that were published in just March only, they said that all the 4 agents like ARNI, MRA, beta blockers, and this SGLT, they should be started at the outset only. Only then those should be downgraded as per the patient's profile.
So early initiation as soon as possible is your recommended approach. And
yes. Early initiation, and also I just want to see that the patient's heart rate is always around 60. If the patient's heart rate is not controlled with beta blockers, I try to start with Rivaroxaban also as soon as possible. Because if the patient's heart rate increases, the EF automatically improves.
Correct. Dr. Ashish, hello.
Hello, sir.
How are you doing?
I'm good, sir. How are you, sir?
All good. So, any experiences with the Eplerenone?
I don't use much, sir. I use spironolactone.
Same here. I swear, same here. Dr. Kuljit, for you, you're using spironolactone more? Or?
Sir, I'm only using spironolactone, not Eplerenone.
Dr. Sanjay?
I have experience with spironolactone.
Sir, I use Eplerenone in the patients who are affording, because it always Eplerenone gives good results as compared to spironolactone. And
frankly speaking, we don't see that much gynecomastia, at least at 25 mg.
Yes, that's true. That's true.
Most of the patients, they are at 25, at least in my practice, and
even at 50 mg also.
Gynecomastia.
I always give only spironolactone mainly to the patients, Eplerenone who are affording, and who sometimes say that I have seen few patients who come to me after giving spironolactone. These are the latest guidelines they are giving Eplerenone. Shouldn't we start with that?
Okay.
But gynecomastia I have seen just in one patient in my practice till date. And
Dr. Ashish, any idea about the incidence of hyperkalemia? How many times you had to stop the drug?
Sir, maybe in 100 patients, 2 or 3 patients I would have stopped. Not much. Yeah. So the only thing is we need to keep track. We need to keep a good follow up of the patient.
So most of the times, most of the studies also documented a hyperkalemia rate of around 5 to 10%, depending upon patient population. So I think that is a acceptable kind of percentage. Anything else you would like to contribute, Dr. Ashish?
Sir, apart from this indication of heart failure, actually we are using in cirrhotic patients also.
Okay.
Yes.
Aldosterone antagonists. Those who have ascites. And other textbook indications are refractory hypokalemia, but we are using in that actually.
I'm using it in some patients of hypokalemia. I have one patient who used to have severe episodes of hypokalemia. He is a fellow of Thapar University, and he once went to Singapore, and there he had to be admitted due to hypokalemia. So right now I'm using Creatinine on that patient for hypokalemia, as well as being at a antihypertensive agent. It is giving good results in that patient.
Yeah,
that's
I'm
very rare
also using
but
the patient also using with hypokalemia. The dose up to we are using spironolactone 200 milligram up to 200 milligram. There is no any side effect of gynecomastia seen in my clinical practice. Only 1 to 2%. Only 1 to 2.
200 milligram per day.
FC. Sir, yeah, 200 milligram per day in cirrhotic patient with hypokalemia.
Maybe he had some amount of gynecomastia already.
Might be,
On a
sir.
lighter
Might
note.
be.
On a lighter note. Dr. Johnny.
Hello.
Dr. Johnny, ki hal chal?
Bas vadiya, doctor.
Any comments you'd like to make?
Doctor, I am sitting in an area where very few investigations, not even BNP or ECO, all the thing, everything is based on clinical.
Correct, that's correct.
That is. And the most of the patient, they come in last failure, just a grade 4 failure on the deathbed. In that condition, we cannot refer the patient. We have to deal, and only after discharge, a few days, 3-4 days, we have sent. We can go for echo or any further investigation.
That's correct.
Any
more? Any further comments?
100% spironolactone. No experience with Eplerenone.
I don't remember starting Eplerenone till now for any patient. Any further contributions, comments, sir?
It's generally, hello sir. Hello sir, I'm Prashant Mittal, sir.
Hi, Dr. Prashant. Actually, your name was coming as I think it's
just I got to know that, sir. I changed it only. Yeah. So actually, I'm using this drug quite often, sir, and I don't think there are so many side effects we encountered in routine practice.
Exactly.
Yeah.
And the cost is very,
Yeah, it's very economical.
Prohibitive.
Economical.
Spironolactone versus Eplerenone.
Yeah. Spironolactone, sir.
Yeah. That is very affordable.
Yeah.
Any further comments or queries? Or I think
I'd
we
like
can
to
hand over to Japesh. Japesh?
I'd like to say something, sir.
Yes, please. Go ahead, Ashish.
Yes. Sir, regarding pro-BNP, anti-pro-BNP, here I'm using, actually I'm not using frequently, to be honest. It's mainly the clinical thing, chest X-ray patients, clinical condition that matters to me. Pro-BNP, mainly I'm using in doubtful cases, actually, where I'm not sure whether the symptoms are due to heart failure or otherwise.
Yeah, as per availability, as per the affordability status also.
Yes.
Some amount of clinical diagnostic dilemma. I think all these factors, they contribute to the use of biomarkers, at least for the heart failure part.
Yes.
So BNP, anti-pro-BNP, most of the times it is a clinical diagnosis. I think we are stuck in 10 to 20% of the patients, if at all.
Right.
The patient is cardiac patient or a pulmonary patient.
One thing, anti-pro-BNP is very helpful in patients who are to be diagnosed HFpEF, heart failure with preserved ejection fraction.
Exactly.
Yes. Exactly. That is the one. That is the yes.
With preserved EF, we definitely see. I think we don't see that much. लेकिन हमारे पास आ ज़्यादा रहे हैं वो. We fail to recognize them unless we do the biomarkers.
Yes, sir. But if we start with some treatment like this MRAs and ARNI, I've seen good results in some HFpEF patients also.
Okay.
Yeah, but the main factor that I've seen in few HFpEF patients and also in patients of heart failure with reduced ejection fraction is their cardiac rehabilitation.
As in?
We are not using this cardiac rehabilitation part very much. I have a setup with me for cardiac rehabilitation, but I have enrolled I think 10-15 patients, and it is giving very good results.
Cardiac rehab has always been a part of literature, sir. I mean,
it is a part of literature, but we are not using it as much.
I'm just talking about going back in time. Whenever we have read, we have prepared for exams. Cardiac rehab has always been a topic, but as you have rightly pointed out, we don't practice it much. That is what you wanted to underline, and I also want to emphasize that cardiac rehab is a very essential part, which is largely overlooked in this part of the globe. Very correct.
I have started individualized cardiac rehab programs. I have few patients and they have given me very good results. There was one of a patient who had a EF around 20-25%. His EF is now just 30-35, but he's right now cycling for around 1 to 2 hours a day with just cardiac rehab and GDMT.
That is way more than what we are cycling.
Yeah.
Dr. Prashant?
Yes, sir.
Back to you.
Yeah, sir.
We got diverted for a while.
No issue, sir.
Dr. Sanjay, how much you charges for cardiac rehab?
So that is usually
rehabilitation
around 5,000-6,000 per month.
Per month. Okay.
Yes.
Okay.
Yes, very nominal actually.
Yeah, I am using my even we do echo and we give individualized approach to the patient, and we usually if the treatment is to be changed, we just ask the physician to change it. We don't change it at our level, because then the trust of the physician is also there, and the confidence of patient is also built that the treatment is being changed only by the referring physician, not by the person who is doing the cardiac rehab.
Okay.
Any further discussion, or we can hand over back to the CIPLA team? Japesh, you're there? Hello?
I think we should close it ourselves.
Arvind sir.
Yeah, sir. Yeah. Dr. Deepak, if you may ask to some question, if you have, sir. So we have 5 to 6 minutes. We have, sir.
Sir, the meeting is for 45 minutes. That is for compliance.
So any discussion, your discussion you can discuss here, sir, because I think this is very good program going on, sir, and I have seen some good discussion on heart failure, sir.
Deepak sir, I'm Colonel here, sir, ABM sir. So I have, sir, 2-3 questions, sir. If you allowed me, though, I can ask you, sir.
Yes, please, Colonel, go ahead.
Yeah, sir. My question is that in anti-proBNP are above normal levels, then whether such heart failure patients are considered for pharmacological intervention?
Pharmacological intervention, as in? If the anti-proBNP is elevated.
Above normal, sir. Yes, sir. Above normal.
Okay. What do you mean by pharmacological intervention? Your voice is breaking up very badly.
So now it is clear, sir?
He is traveling, sir, so that's why his voice is cracking, sir.
Hello.
It's a very
so now my voice is.
That I'm able to hear.
Hello.
You are audible, but not completely, Colonel. There's a lot of background noise behind you.
Yeah, I think he's traveling, sir, so that's why a lot of noise is here, sir.
Yes,
any question from any delegate, sir, which you can ask from Dr. Deepak, sir? So we have 4 or 5 minutes, sir. You can ask any question, and any your thoughts you can share here also.
I think we're done here.
Hello. Hello, sir. Now my voice is clear, sir?
Yeah, you are audible.
Yeah, sir. Sir, what percentage of heart failure patients on MRAs developing hyperkalemia require discontinuation of treatment?
Yeah, I think usually we don't see more than 3 to 5% of patients going on to hyperkalemia, and if at all, even there is a single instance of hyperkalemia, my practice is to stop the MRA as soon as I get to know the episode. I don't wait for the second, third reading of potassium. I would like to stop it and be safe. So stopping the MRA is almost absolute, but encountering hyperkalemia is not more than 5% in my practice. But if the patient does develop hyperkalemia, I stop the mRNA for a month at least, unless I get very safe potassium levels without the drug.
Sir, one more question. What should be the frequency of testing the potassium level, creatinine, and Egfr?
I think potassium levels every 2 weeks are fine. I don't know what the guidelines suggest, frankly speaking, but I think every 2 weeks, if I can document.
After initiating MRI, sir.
After initiating MRI, yes. After 2 weeks, I would suggest. I'm not sure what the guidelines recommend. Creatinine and all can be monitored, I think, every 1 to 2 months. Potassium needs a closer watch. Any comments on this one from other panelists?
Yeah, definitely, sir. Definitely.
Dr. Deepak, one question. In which class are you using MRA?
Sir, at least class 2.
Class 2.
Class 3 and 4. Usually class 3 and 4. I'm very clear about it. I use diuretics, ACE inhibitors or ARNIs to the full, beta blockers.
And what is your experience?
Experience regarding?
MRA.
I think they should be used, sir. Definitely used. I don't use it in all the patients, like the guidelines do suggest. I think the BP does not permit. Most of the times, the available blood pressure of the patient is consumed by the ACE inhibitors, ARBs, ARNIs, beta blockers, diuretics, and I think MRAs are not used that frequently by me also. That is my personal thing. But if the BP is permitting, I like to initiate all the agents available, all the categories, and then go on escalating the dose. But
are you using as a first line or as a second line, third line?
Maybe a third line. Maybe a third line. ACRB, ARNI is the first line, beta blockers second, diuretics third, and then maybe third, fourth line. Yes.
What about ARNI?
And definitely, I mean, in post-MI patients, I'm using MRAs earlier. ARNIs again, I have not switched to ARNIs in totality. In a majority also, I have not switched to ARNIs. Only if the patient is still symptomatic on ACE inhibitors, ARBs, I am shifting to ARNIs. And again, the cost concerns do remain on my mind.
What is your experience with ARNI? In which patient about ARNI?
Patients who continue to be symptomatic on GDMT, including a good dose of ACE or ARB, or only these patients who are intolerant, like, you know, they are still symptomatic, continue having admissions, or obviously a very affording patients, I am totally okay with ARNIs, but majority of the patients, affordability is an issue, and I like to stick to conventional ACE inhibitor or ARBs at the start.
And start what dose?
Depends on the agent, depends upon the BP. So start slow, start gradual, go slow. At the same time, keeping the symptoms and BP and other parameters into control.
Thank you, sir. Thank you.
Thank you.
Sir, Karnal here, sir.
Yes, sir. Any question from sir, Dr. Johnny, Dr. Prashant, sir, Dr. Sanjay, Dr. Ashish, sir? Or any thoughts for on heart failure, sir? If you comment 2 or 3 minutes, sir.
I think we had a good discussion.
Yes, sir. Yes, sir.
Sir, Jagjit here. One question from me, sir. सर एक जनरली क्वेश्चन पूछ रहा हूँ, हार्ट फेलियर रिगार्डिंग नहीं है, मुझे ये पूछना था, बस ये बता दीजिए, अगर किसी पेशेंट को समझ लो टॉसिमा 20 mg को स्टेबल नहीं हो रहा, हम हायर डोज देते हैं, समझो टॉसिमा 40 mg, आप ये प्रेफर करेंगे कि एक स्पाइरलवेक्टन ऐड प्रेफर करते हैं ज्यादा? मुझे जनरली ये पूछना था। एड ऑन है, एज ए एड ऑन, कि आप हाईएस्ट स्ट्रेंथ को प्रेफर करते हैं कि एक साल्ट और ऐड करना चाहते हैं?
Given the scenario 20 increasing to 40, I would like to add another agent. I would like to look into the cause, why the patient is not responding, what is the reason behind the non-response, what is the heart rate of the patient, what is the BP, is it permitting enough, to increase the diuretic, or I can gradually increase the beta blockers, what is the heart rate. There are a number of things which have to be looked into before I will, and definitely given the scenario, 20 mg of diuretic, if it is not doing the trick, I think we need a new agent, because let us face it, 100 mg wali dose is mostly by the nephrologists. 100 mg, 80 mg, 60 mg.
Yes,
We
sir.
don't see many of us. I don't see many of us. I don't see myself ever, and I don't see many of us writing 40 mg of Ditor and 80 mg of Ditor. So I would like to add on another drug and optimize it rather than increasing the diuretics. Leave that part to the nephrologist.
Sir, one question more. Patient heart failure patient with CKD, how to treat with CKD?
I have the luxury, refer to nephrologist.
Hello, Deepak
The
sir.
role of BiPAP is, sir, what about role of BiPAP in that patient?
Acute episode, definitely yes. It is a big yes. If the rate is controlled, if the BP is optimized, if there is no obvious fluid overload, patient still continues to be symptomatic, intermittent BiPAP has a big role to play.
Hello, Deepak sir, Karnal here.
Yes, Karnal.
Sir, just two last questions, sir. One question is, sir, how do you manage, sir, hyperkalemia while using ARNI, sir, in patient? And second question, sir, what is your experience using ARNI with device therapy?
ARNI with device therapy?
Yes, sir. Like the person who is having a device in their heart, sir. So, and that kind of patient, you are using ARNI. So, what is your experience on that, sir?
I don't see the relevance of the question at all.
Okay, sir.
ARNIs don't say anything to the device. The device doesn't have any problem with the ARNIs. I don't see the relevance of the question at all.
Okay. And sir, the second one, the manage of hyperkalemia while using ARNI.
You stop the ARNIs as well. As per the level of the potassium, either you can start potassium binders, bring the potassium down to acceptable levels, and then go back to some other drugs. But definitely you have to stop them as well.
Okay. Okay, sir. Okay, sir.
Yeah.
Fine, sir. Fine.
Thank you very much, sir. I think this is a very good discussion, sir, on heart failure, sir, and it was good interaction. So, any other questions, sir? Any delegates you want to ask, sir? Otherwise, we can close, sir.
Yeah, we are good to go.
Yeah. So, I think no questions from anybody, sir. So, thank you very much, sir. Deepak, sir, especially, sir, you have given this precious time to us.
Yeah, thank you so much.
And also, thank you very much for all the delegates, sir, who have given this precious time for this wonderful session, educational session, sir. And hope, sir, this is very much helpful and very much useful time for all of us, sir. And we will do this type of program in future also, sir.
I would also like to thank Dr. Kuljeet, Dr. Ashish, Dr. Prashant, Dr. Johnny, Dr. Sanjay personally. And thank you for joining.
Thank you, sir.
Thank you for having us. Thank you.
I also thanks to Dr. Katyal and all the delegates, because Dr. Katyal has shared his experience very, very much. We are thankful to him. He has given us opportunity to.
Thank you, sir. It was a pleasure.
To a nice discussion.
It was a
thank
pleasure.
You, sir. Thank you.
It was a pleasure. Thank you.
Thank you, sir. Thank you very much, sir. Once again, thank you very much by heart, sir. Thanks, and thanks for joining.
Thank you, sir.
Thank you, sir.
Thank you.
Thank you, sir. Thank you. This was wonderful session, sir.
Thank you.
And thank to you all delegates, sir, for attending this session.
Thank you.
Thank you, Dr. Sanjay, also.
Good night, all of you, sir.
Good.
Thank you, sir.
Good night, sir.
Thank you.
Good night. Good night.
Good night, sir.